75, or they can be under the age of 75 with multiple comorbidities. Overall, most patients are very medically complex from all socioeconomic spheres. Patients belong to different ethnic and minority groups. So it's a very diverse patient population with an entire spectrum of needs. Patients with different levels of functioning, social support, financial stability, and we have many patients whose primary language is not English, so quite a range of needs. So just a little bit of background. So the first vaccine was delivered in Colorado on December 14th, 2020. And then on December 30th, 2020, the state began phase 1B, which expanded the eligibility pool to adults 70 and older. So of course, this was going to include patients at our University of Colorado Seniors Clinic. However, this vaccine rollout was going to rely on the online portal, My Health Connection, to distribute invitations to schedule a vaccine. And then once these invitations were received in a patient's inbox, it would expire within 48 hours. So as you can imagine, this was going to pose quite a challenge for our patient population. So of course, there are going to be barriers to access for this. So, our patients have a lack of access to and quite a lot of difficulty utilizing technology. These patients are mostly in their 70s, even up to 100. And they tend to suffer from high-risk geriatric syndromes. So they have severe dementia, history of severe stroke, immobility, blindness. Many of them rely on caregiver support, and their children are even in their 70s, who probably have pretty low technology literacy. Many of them don't drive and have limited transportation. So how are they even going to get to this scheduled vaccine if it even is able to be scheduled? Many of them are on Social Security. So this is, a lower economic group of individuals. And then many come from racial and ethnic minorities, including those with limited English proficiency, as well as many cultural and community factors, which would pose a barrier. So given our patient population and their very diverse and specific needs, we kind of knew we had to do something more personalized than just relying on an online portal for patients to schedule a vaccine. So the goal of this quality improvement project was to improve COVID-19 vaccination rates among seniors clinic patients. And this we decided to do through telephone outreach with a focus on assisting underserved older adults. And then kind of quickly into the project, we realized we really needed specialized outreach for patients with limited access to technology and for racial and ethnic minority groups, especially those with limited English proficiency. So we launched this QI about 2 weeks after the vaccine became available to our seniors clinic patients. So it's actually still an ongoing project. But I'm just going to be discussing what we did from January 16th to February 23rd, even into early March. So how did we kind of mobilize help to do this? So we were able to recruit and train 32 students from both the School of Medicine and College of Nursing at the University of Colorado. And we recruited them to do this telephone outreach where we'd be calling all of our seniors clinic patients. In order to do this, they had to participate in an hour-long Zoom training session. And here we provided them with an online manual that was accessible 24/7, and went over with them, how do you do an EPIC chart review and look up a patient in EPIC? What should they be looking for in their chart? And then a script to provide answers to common vaccine questions. Probably one of the biggest barriers we hit first with trying to mobilize this so quickly was just EPIC remote access for students. It was actually quite difficult to get, even though they were all actively enrolled students. And then in terms of kind of answers to questions that they would typically field, we educated them on the Moderna and Pfizer vaccine, which is what was available at the time. Common side effects patients could expect, fevers, chills, fatigue, arm soreness, malaise. And then at the time, originally, anaphylaxis was a huge concern. And those were quite a few questions that came up. So we educated them on how to address allergy concerns. And so students had access to this Excel spreadsheet that had the list of patients' names, their MRNs, and their primary language, along with a few other data points that we wanted them to collect during their telephone calls and chart review. So primarily, we made sure that the first question they asked was, are you even interested in the vaccine? And have you already received the vaccine? And if so, where did you receive it? And most importantly, are you able to access your My Health Connection account? Since in the beginning, that was the only way to schedule a vaccine. Do you need caregiver assistance to schedule? And do you have transportation to get to a scheduled vaccine? And then we kind of started to just keep track of patients who really would not be able to schedule online in the hopes that a telephone scheduling option would become available, which it did, and which I will talk about. So this was a really dynamic, kind of fast changing project, as you could imagine, since the vaccine distribution options kind of changed day by day. So we initially started with this general call list. And what this was just a roster of patients who had a My Health Connection account. And we were calling them and just making them aware of this online invitation system. But at this point, we really had no way to schedule them ourselves or even let them know when they would receive an invite through their My Health Connection account. So this was really just awareness outreach that they need to, one, do you have access to your My Health Connection account? And two, if you do, you need to basically check it daily to see when this invitation will come in. And then kind of most importantly, we provided them with a My Health Connection tech support number, which they were able to call, and they can troubleshoot access to their My Health Connection account. And this was typically patients who had caregiver support, and the caregiver was managing their My Health Connection account. So after probably about a week or 2 weeks, we were able to figure out that we could generate a list of patients through Epic who had received an invitation to schedule a vaccine through their My Health Connection in the last 12 to 24 hours. But the tricky thing with this is that these invitations expire within 48 hours of receipt. So we kind of had to act fast. So basically, once we figured out we could do this at the end of the workday, so usually around 5 p.m. in the evening, we were able to generate this list of patients who had received the vaccine invitation at some point in that day. And then we basically emailed all of our wonderful volunteers and said, if you have any time, please call these patients. Their vaccine invitation will expire anywhere from the next 36 to 48 hours. And the response was really incredible. People were extremely generous with their time. And then at this point, another change that had happened was there was a COVID hotline number that wasn't really widely publicized, that most of our patients did not know about. And this COVID hotline number, if you had an active vaccine invitation in your inbox, you could actually call the number and they could schedule it for you. So that was a huge help for our patients who are just not going to be able to use the computer. And then we had these last minute mass vaccination events that we would kind of find out about at the last minute. So kind of the first big one that's notable is there was a vaccination event at Coors Field on January 31st. And we probably got, we were told about this about 24 hours in advance that they were going to have some openings and if we had any patients that would like to come. So, you know, with the help of our wonderful volunteers, we actually were able to call 142 seniors clinic patients that day and got 31 to receive their vaccine the next day at the mass vaccination event. And then there were some community events, the New Hope Baptist Church and Colorado Community Church, which I'll talk a little bit more about. So we kind of noticed we did have to even further specialize our outreach, especially for minority patients and those with low English proficiency. So we trained students to use the University of Colorado Translation Service to make phone calls. We employed the help of multilingual students who focused on outreaching patients with whom they had a shared language. And then we connected with local vaccine events who are helping to increase vaccination rates among patients belonging to ethnic and minority groups. So that New Hope Baptist Church event that it was held on February 13th was actually coordinated through the Colorado Black Health Collaborative and the Center for African American Health. And here is just some preliminary data. We're still in the process of statistically analyzing all of our data to really kind of quantify the rate of change and the correlation with our vaccine outreach, but the raw data actually looks pretty promising. So this graph over here on the left, so we started with about 20% of kind of our seniors clinic patients vaccinated, and these are all of our kind of total patients in clinic. And kind of these letters correspond to this table over here, which is basically the type of outreach we were doing at that point in time. And then we broke it down into patients who did not have patients of color on this line. The gray line are limited English proficiency patients, and then patients who did not have a My Health connection. So definitely a positive trend. And then this, I think, is the most interesting. So this is just raw data in this table. However, on January 16th, there were only 31.8% of seniors clinic patients who were actually vaccinated. And as of April 14th, almost 75% are now vaccinated. And then in the beginning of our initiative, only 2% of patients had a My Health connection account. Now over 50% do. And then only 12.5% of patients with limited English proficiency were vaccinated at the beginning, and now over 65% are vaccinated. And then for our patients of color, we started with 14.8 and now over 68%. So really, really exciting. And overall, we called about 2,263 patients. And this was with the help of only 32 students, along with myself, Dr. Tasmia Ahmed, Dr. Hilary Lum, and Dr. Sarah Teets. And all in all, there was probably about 500 hours of telephone outreach put in a very short period of time. So just kind of a quick discussion, and what we really kind of took away from this is the need to really be thoughtful about vaccine distribution. There are going to be so many barriers, and really having to adjust to serve your patient population appropriately. And the need to be extremely adaptable. I mean, we would send an email and then send another one an hour later with a change. So it was an extremely dynamic process, which was fantastic because it was usually positive changes and more access to the vaccine. However, it really made it difficult for kind of quality data collection, but we tried our best. And then also just paying attention to your specific patient populations that are going to need specialized outreach. So before I turn it over to Rachel, who is one of the medical students who is heavily involved with making phone calls to answer any of your questions about the process, I just really want to thank all the students and faculty who made this possible, specifically all of the nursing students from the College of Nursing who volunteered, and our medical students from the School of Medicine, along with Judy Davidson and Carrie Coe from the College of Nursing, and then our seniors clinic faculty, especially Dr. Sarah Teets and Dr. Hilary Lum. So Rachel, I will hand it over to you. I don't know if anyone has any questions about the process, changes we made, any specifics.
Yeah, I guess I'll start first. Can you hear me? Let's see.
Yes, you're great, Rachel.
You can hear me? Okay, it wasn't lighting up. I wasn't sure, sorry. So from a student's perspective, I mean, this was just such a rewarding experience to be a part of. I was really impressed with the haste that Dr. Teets, Dr. Lum, Dr. Azelby, they're able to recognize that there was this disparity in the senior population and be able to mobilize this large group of students to be able to get this together and to help our seniors. Especially since it was such a personalized project where we were speaking one-on-one with seniors, calling them and hearing the excitement in their voice, and being able to get them scheduled for people who normally probably wouldn't have access to the vaccine for a while because of the disparities that they had with internet connection, with technology, with being able to get to these locations. It was incredibly rewarding to be able to feel like we were making a difference in the community. So it was a very awesome project.
A couple questions guys from the chat. So Jeff Wallace asked, he said, amazing effort and efficacy. Did Epic allow you to identify which patients did not have My Health Connection, or did you have to sort that out on the fly? I don't know, Chris, if you know that answer.
Yeah, so we were able to actually, when we generated the roster of patients, it was only patients who had a My Health Connection to begin with. So Epic was actually able to tell us that, as well as if their My Health Connection account was active or not. So initially we were only contacting patients that had a My Health Connection, since that was the only way to get the vaccine. And then we started kind of quickly digging into patients who didn't have it. So Epic was actually able to provide us with that information pretty quickly.
Great. And then Carrie Levy asked, are those new My Health Connection, or those with new My Health Connection accounts still using them? And I don't know if you have much experience with that, or I can speak to my experience just on my panel too, if that's helpful, Chris. I don't think they are. So those who didn't have a My Health Connection account before checked every day till they could get the vaccine, and then don't seem to be continuing to use those accounts still. At least in my experience.
Yeah, I would agree. But great question. We should probably we'll have to kind of check.
All right. And then just Hillary had made one kind of clarification on one of the graphs. It was people who didn't have My Health Connection increased from 2% to 51%, not people with My Health Connection. But as a clinic, we did increase the overall My Health Connection account rate from like the mid 70s to 88%, with really encouraging people to sign up. Do you guys have, Rachel or Chris, do you guys have any examples of family involvement in this process? Like when you called patients, and how you involved families and caregivers?
Yeah, I feel like most of the time when I was making calls, I was speaking to a caregiver, and so that was good to see that they were so excited to get their loved ones the vaccine. So I know when I spoke to some, there was some frustration about the rollout and how we were doing everything, and so it was great to be able to have that specific outreach to cover that disparity that was being caused, and so everybody was super grateful.
Yeah, and in my experience, even just, we started, this I didn't mention, but we started leaving voicemails once we had the urgent invitations. We only had 48 hours to kind of get them scheduled. And a lot of the voicemails I left for family members, I think nearly all of their vaccines got scheduled.
Awesome. Do you guys see any kind of ongoing challenges at this point in vaccinating our older adults?
So yes, I'm sure there are. I think there are still kind of a small group of patients that are concerned that there's not enough data. I see that more actually at the VA than at seniors clinic, which is kind of for a whole other set of reasons. So once again, these kind of cultural and community factors. But otherwise, I mean, I think it's been fantastic. Like, our patients have really responded well. Everyone wants their vaccine. This has hit them the hardest. They're extremely excited to get back with their families, get out in the community. So I'm hoping that those numbers will be extremely impressive by the summer.
Yeah. And I think there still seems to be a group of patients who are unable to get out of their home very easily, who haven't been able to get transportation to and from events, especially with really significant mobility issues.
Mm-hmm.
I think that's the other major group we still have to try to reach.
Yeah, and actually at the VA, we've done, it's kind of been interesting being at the VA and at seniors clinic, which is seeing the different types of vaccine rollouts. But at the VA, we have started vaccinating our home-based patients. So actually bringing the COVID vaccine into their homes, which has been really cool.
Yeah, awesome. That would be great. All right. Well, thank you guys so much for presenting, Chris, and for Rachel being here to present. I'll hand this over to Hillary, and she'll introduce Thomas's video, and then Hannah.
Thanks so much for this presentation and the work. And as individuals are logging in, feel free to add chat questions about the vaccine outreach, and we can answer them on chat. I'm also really glad that these are recorded. That was a terrific summary and presentation that I'm glad will be accessible to individuals, you know, on our GREC website. So I am going to find my introduction. We are now going to transition to two poster presentations that will be presented at American Geriatrics Society. And the first one is by Thomas Johnson, who actually is not able to be present today. He will be presenting at American Geriatrics Society. And this year, as many of you know, as a virtual meeting, many of the presentations are pre-recorded. So we have ability to show his recording. So please do chat in questions. Adrienne Brungart is one of the care team navigators, and she will join us as a panelist to help answer any questions after Thomas's presentation. And then Hannah will be presenting her poster and discussion afterwards. So that's our next plan for Grand Rounds. So Dr. Thomas Johnson is a third-year medicine resident and a future geriatrics fellow here at CU. When college football is out of season, he can be found hiking, reading, or exploring the food and drink scene in Denver. So let me figure out my tech to make sure I can show his video. This is the challenge of having many things on one's desktop. And I want to make sure I show you the correct video. Talk amongst yourselves, which would work if we were actually in a room, which maybe we'll be back soon. Let me find it in a different place. And if anyone has any questions for our folks, that would be great. I did find it, so I am saving it in the appropriate place so that we can play it from my desktop and hopefully it won't crash. Okay, so I am getting it started, I believe.
Support program and what impact it has had on.
All right, are you able to see it coming, hopefully?
My name is Thomas Johnson. I'm a third-year internal medicine resident at the University of Colorado Internal Medicine Residency Program and a member of the primary care track. I'll also be a geriatrics fellow at the University of Colorado next year. Today, I'll be talking to you about our dementia caregiver support
Seems like
program.
not yet. We'll figure this out. I can see it running here, but I need to. Let me try again. The webinar setting is different than the standard Zoom, which is what seems a little odd, but let's see. Any luck?
No.
Hmm.
You could, if you wanted to try to send it to me maybe, and Hannah.
Yes, I will do that. Yes, so we'll switch up. Hannah, if you could go next, and then we'll do Thomas's later. We will adapt in the moment. So I'll share your intro, Hannah.
Sounds good. Thank you.
All right, so Dr. Hannah Schara is a graduate of the CU School of Medicine. She is a primary care resident with an interest in geriatric medicine, applying currently. She enjoys spending her free time with her 2 daughters, husband, niece, and nephew. So thank you so much for presenting today, and we're excited for your AGS poster.
Thank you. Okay. Okay, can you guys see my slides?
Yes, you look good.
Okay, great. So my AGS presentation is titled Dementia Care Navigators Provide Specific Caregiver Support and Coordination in Primary Care. This was in conjunction with kind of all of the Living with Dementia team, including Adrian, Thomas. Oh, let's see here. I think it's gonna keep going. Bummer. Prajakta, Hillary, and Barnett, and other providers that kind of helped with this program over the past few years. Let's see here. As far as kind of overall background for this program, you know, in general, caregivers of persons with dementia have shown to have kind of overall poor outcomes, less quality of life, less positive interactions and positive experiences than other caretakers of persons with other kind of end-of-life conditions. And so it's definitely a group that's very in need and that kind of overall is not doing well. And so they were kind of the target of this overall program. The Living with Dementia program itself is a kind of a longitudinal quality improvement program run at the Seniors Clinic. It was adapted from the Care Ecosystem program that was initially developed by the USTF program, in San Francisco. And it's basically where they take a care team navigator that is a non-licensed but trained provider who does outreach for telephone outreach for persons with dementia and their caregivers. And it's a caregiver based program where it's kind of based on the needs of the caregiver, and they're kind of the ones leading the conversation, leading the program. And so the idea of this research was to kind of look at the care team navigator notes and really determine what were the topics that came up, what are the caregiver needs overall, and those are kind of what we looked at, as well as what are the type of referrals that are most utilized by the persons with dementia and their caregivers. So the methods that were developed for this program, it was obviously within the geriatric primary care setting, and it was me and Thomas and I, and we did qualitative content analysis. So we just used Epic EMR and went through and kind of looked at all of the care team navigator notes. Those ended up being 491 notes over the study period, which we did September 2018 through March of 2020. The total dyads that were enrolled in the program that we looked at were 66. And we used a team-based approach, and we would meet usually monthly to kind of go over and determine, you know, how closely we were coding together. And we did this with Adrian. We were able to kind of use 8 specific dementia education support topics. And those included caregiver well-being, ADLs, IADLs, behavior management, long-term care. Let's see here to go over all of them. And those we were able to kind of have 8 major categories, and then those were subdivided into subgroups as well within those categories. We looked at kind of the overall frequency of those dementia topics, the frequency and type of clinic care coordination, and then whether those referrals were within the community or if they were within the primary care setting, and we kind of looked at the frequency and the differences between those. For the results of the study, so the table on the left kind of shows the overall conversation topics and the number of times those came up throughout with the dyads, and then also the percentages of those as well. The three most common topics that arose from the notes were caregiver well-being, behavior management, and specific referral assistance. We also were able to kind of, we looked and categorized also the first three main topics to look at what were the most common subtopics within those. For caregiver well-being, we found most commonly it was caregiver empathy and support, and then also efforts to increase caregiver support as well. Behavior management, the most common subtype within that group was communication skills. And then for specific referral assistance, the most common was social work and primary care, or I'm sorry, and PCP were the most common conversation subtypes within those. And then we also subdivided and kind of looked at the specific referral assistance as well. And the most common referrals inside the clinic were the social work and PCP. And the numbers listed to the right on the table to the right are actually the percentages of the amount of times those referrals came up. So for social work and PCP, that came up 22% of the times out of the overall dyads that received a referral. And really the majority of the dyads had some sort of referral that, and so it was 54 out of the 66 dyads that had referral assistance. Sorry, this is set up for my recording, and so I think it keeps going ahead. And then the most common referrals that were outside of the primary care setting were skilled home health, Alzheimer's Association, and non-skilled home health. Not listed in this, but kind of the overall demographics of the dyads themselves that were involved with the program. So the average age of the person with dementia was 83. The average age of their caregiver was 68. The majority of those were women. The majority of them were Caucasian. And then most of those had a higher education. So 43% had a bachelor's education or higher. So as far as kind of the conclusions that we came to through this research is just that overall caregiver support with conversations, there was kind of multiple needs discussed. We were able to pinpoint kind of what the caregivers brought up most commonly, but there was definitely a very broad spectrum of conversation topics that are discussed throughout this program. Caregiver well-being and behavior management of the person with dementia seemed to be the topics that were most in need overall. And then, I think looking at this program, it was clear to see just that having the care team navigator integrated into the primary care setting was really helpful in helping to coordinate the referrals. The majority of those were within the primary care setting, but quite a few also, they were able to help kind of connect the caregiver with community referrals as well. Okay.
Terrific. Thank you so much. I appreciate your presentation. Would love for people to chat in comments or questions related to this talk. Hannah, I'll start with a question. So you had a comprehensive list of categories. How did you come up with that list, those 8 topics that you were then judging whether a referral existed in that category?
So for the 8 topics, I think they were initially based off a REACH handbook, which is a caregiver handbook for persons for caregivers of persons with dementia. And so those were kind of the initial categories that we came up with. And I think overall those worked pretty well. And we were able to utilize most of those. Within the subtypes, we had to kind of make some changes based on those, but for the main 8 categories, those worked pretty well. And then for the referral type, we kind of came up with specific coder guidelines for how those were utilized. And then for I think for coding for referrals, there was a lot of difficulty or just kind of getting kind of consistency within the referrals because sometimes they were brought up frequently. They weren't always utilized. We did count referrals whether they were for the person with dementia or the caregiver. And so there was even some care coordination of the caregiver themselves to kind of help them find behavioral health services and kind of connect them. So that was neat to see as well. It wasn't just always referrals for the person with dementia.
And actually, Hannah, I have a question. Great job. So the bereavement topic that would come up, what were patients really discussing? Because I'm, in my mind, I'm thinking that's the caregiver almost grieving this, prolonged loss of a loved one.
Sure.
And I was actually surprised it wasn't higher. So yeah, I'm just curious what you saw on the charts.
So we made that more specific. Our consideration of bereavement was actually grieving a past death specifically.
Okay.
And sometimes I think more like a lot of the caregiver stress or burden with kind of changes was coded into caregiver empathy. And so I think that's a lot of times where those would kind of fall. And so bereavement was specifically caregivers grieving maybe an actual loss. If it was their children, they were grieving the loss of maybe the other parent specifically. And so that's kind of where we utilize that one.
Got it.
I'm going to ask you a leading question. You are in the primary care track, and I know this analysis did not compare what referrals maybe existed in a primary care clinician's note versus what was in the dementia care team navigator's note. You looked just at the dementia navigator's note, but how much overlap do you think there would be in the primary care provider's note and the care team navigator's note?
Yeah, I think that was really interesting for us because these were the topics were specifically caregiver driven. And so for us, what I think focus on the majority of the time in the primary care setting is safety. I think referral assistance is something that we use quite a bit, but I think we focus a lot on education and safety, which were not the main kind of needs that the caregivers brought up. So I think it's interesting to think of when we are kind of setting the agenda for our visits and we have a caregiver present and a person with dementia, and kind of we are often talking about driving, where are the keys, falls, things like that, placement, which I think are important to the caregiver, but definitely behavior management, their well-being, referrals are kind of things that they feel like are more important for them.
Great, and thanks, Jeff, for this question. Adrian, I wonder if you're able to turn your camera on and come off mute. The question is, how long are the average dementia outreach visits? And that data is in this, although not presented, but then Adrian, can you just describe your role and answer of this question?
Sure. There's a lot of variation with that. Normally, I block an hour slot and do have, I would say, probably half of those folks take a full hour of conversation. And then the rest would be, 30 minutes or less.
Yes, thanks. And any other questions from any of the panelists or chatting in?
Hannah, when you look at these different areas that are covered by the care team navigators, are there any themes that you can think of where you think in primary care going forward, it'll make you more thoughtful about offering different resources or about kind of proactively educating about certain things?
Yeah, that's a good question. I think what we learned is some of these, I think one of the topics, safety and things like that are often things that we can just talk about in one visit and be done, where I think a lot of these other problems are longitudinal. And so for caregivers, when they bring up like a behavior management, whether it's wandering or, some other frequent questioning, shadowing, things like that, they're often not solved in one visit. And so I think as a provider, it's, if you're looking back at your notes on what are the things that came up that the caregiver brought up, it's important to realize that a lot of these things need to be discussed, over and over again. And usually they're not solved in one visit. Whereas as different things that we often bring up over and over, like safety and those things, usually can be solved pretty quickly. There's usually easier solutions. And then, just caregiver well-being is something like empathy, making sure that they have support was something that usually needed to be brought up over and over. And just because we talked about it last time doesn't mean it's something that we can kind of, okay, that was discussed, we can kind of move on to other things. But a lot of these, behavior management specifically, I think in caregiver well-being need to be kind of focused on over kind of the long haul.
Well, thank you so much, Hannah. I think one limitation, of course, of the webinar format is that as audience members, unfortunately, you're not able to come off mute. So please do feel free to chat in any comments or into the Q&A. And I'm going to pass it to Sarah, who hopefully will be able to now show Dr. Johnson's presentation.
You guys see it okay?
Good afternoon. My name is Thomas Johnson. I'm a third-year internal medicine resident
it's great.
at the University of Colorado Internal Medicine Residency Program and a member of the primary care track. I'll also be a geriatrics fellow at the University of Colorado next year. Today, I'll be talking to you about our dementia caregiver support program and what impact it has had on participants. We have no disclosures. The challenges of caring for a person living with dementia may be associated with negative outcomes such as caregiver burden, depression, and low self-efficacy. Our clinic sought ways to improve support for the caregivers of our patients, and we found the Care Ecosystem model. Care Ecosystem is an evidence-based dementia caregiver support program that demonstrated efficacy in a randomized clinical trial. The aim of this evaluation was to determine whether an adaptation of this original program into a geriatric primary care clinic improved caregiver outcomes. Dyads consisting of a person living with dementia and their caregiver were enrolled in the Living with Dementia clinical initiative after being referred by their PCP. They met with a trained care team navigator where they had an initial intake, a home visit, and monthly telephone contact. The monthly telephone calls were caregiver driven and had no agenda. The caregivers were also trained in use of the REACH handbook, and the care team navigator assisted with any clinic or community referrals. These dyads were assessed with Zaret Burden Index 4 item, the PHQ-4, and the Care Ecosystem self-efficacy scale at enrollment and at post-enrollment, either at 6 or 12 months. A total of 66 dyads participated in the program during the clinical evaluation period. For the persons living with dementia, their mean age was 83.4 years and 68% were women. For the caregivers, mean age was 68.6 years and 71% were women. 17 dyads graduated from the program or died prior to 6-month assessment. Our program saw significant improvement in both Zaret Burden Index and self-efficacy. The ZBI-4 score improved from 15.6 to 12.4 with small to medium effect size. PHQ-4 improved from 2.52 to 2.22, which was not statistically significant. And finally, our caregiver self-efficacy improved from 10.2 to 12.2 with a medium effect size. We saw statistically significant improvement in both caregiver burden and self-efficacy. Self-efficacy is very important, as in other studies has been shown to be protective against both caregiver burden and caregiver depression. Of note, we did not see improvement in PHQ-4. However, at baseline, the mean score would not have screened positive. This suggests that even improvements in the score may not have been clinically significant. Additionally, this study was conducted partially during the COVID-19 pandemic, which potentially may have masked any additional benefit. And finally, as seen in the control arm of the Care Ecosystem study, caregiver depression actually worsened with usual care. Our improvement in PHQ-4 score suggests perhaps that the Living with Dementia program was protective for our caregivers. In the future, we will need to conduct longer-term and larger scale evaluation of the Living with Dementia program as it progresses and grows in size. We are grateful for all of our clinical staff, patients, and caregivers for their participation in the program and the dedication they continually display. Additionally, we are thankful to Care Ecosystem at UCSF for their open support and collaboration. This concludes my presentation. Please reach out to me with any questions you may have. Additionally, you may find me on Twitter at the handle listed here. Thank you.
Thanks so much, Sarah, for playing that. And we welcome questions into the chat or Q&A. One update that I'll share. So Dr. Johnson mentioned, of course, that this is a small clinical demonstration evaluation. This was pre-post. There is no control group. And really, we were only able to analyze 30 to 40 people. We have now been invited to participate in a multi-site effectiveness implementation clinical trial, again, led by the University of California, San Francisco team. And that RO1 was scored well in April. So we are hopeful that we'll be able to expand our adaptation of the care ecosystem, which is living with dementia here at University of Colorado, and do a more robust evaluation. It's exciting that in our adaptation, we have a preliminary signal that aligns with the initial randomized control trial, and we're excited about the next steps. Thanks, Dr. Schwartz, for this question. Any difference in outcomes between men and women caregivers? I'll answer on behalf of Thomas for that analysis. We did not have a large enough sample to do that analysis. And I'll pass it also to Hannah. I know you didn't statistically look at differences in men and women caregivers, but could you give us a gestalt? And then Adrian, I'd also be happy to hear from you.
Yeah, Adrian might know better just from remembering her experiences chatting with them specifically. I don't remember. I would say the majority of the caregivers were women. And thinking back over the notes I've read, I can't specifically say whether I would see a difference related to their outcomes or if there was more kind of signs of depression based on the two. I don't know, Adrian, if you have if you can specify.
Yeah, I don't know specifics either. Knowing that the majority were women, I think anecdotally for the men, it seemed like maybe I spoke to them for a less amount of time, but I have no idea as far as their specific changes in scores.
It's a great question, Dr. Schwartz. How can we have more male caregivers participate in living with dementia? And we have several of us who are providers on the panel, Dr. Hildreth, Dr. Tietz, Dr. Azelby. From your perspective, do you think that you refer male caregivers less frequently to living with dementia, or what might be happening there?
I think, don't quote me on this, but I think that male caregivers are less likely to experience caregiver burden and rates of fatigue and caregiver burnout. And so I guess I tend to refer the people who I feel like are experiencing more burden, although maybe I'm just not asking male caregivers as much, and maybe I have some kind of unconscious bias. So maybe I should be thinking about that a little bit more often.
Yeah, it's a great question. There aren't that many of male caregivers. I'm trying to kind of go through my Rolodex and now that you mention it, there is one who on my panel that would probably benefit. So yeah, I'm sure there is an implicit bias, absolutely, for not referring them. It's very thought-provoking.
In the Living with Dementia program, an analysis that we could do, especially as we're bigger and hopefully able to see whether there are any gender differences and also relational difference. So is it a spousal care partner or a child-parent caregiving relationship or a family friend support relationship? I think we would be able to then also look at frequency of check-in by the care team navigator, length of those conversations, as well as topics. So, and then care partner reported outcomes. So I'm glad we were able to sort of share with this audience both sort of reflections of the preliminary data that we are able to collect as we try to understand better what the impact of this program may be on our caregivers, hopefully of an increasingly diverse type of care partner. And thanks, Dr. Schwartz, there are more female individuals with Alzheimer's and related dementia, so there must be lots of male caregivers. Or I think we also see that there are a lot of daughters and women from the family unit that step in. So that's all. We certainly see that in our Living with Dementia program also. Any other questions, comments? Well, thank you to all of our presenters and to the audience for joining us today. Dr. Hildreth, are there any closing thoughts?
No, I just thank you all for participating and pulling this together, and Hillary for organizing and making all the video work. I know it's challenging. So really appreciate everybody participating, and look forward to seeing everybody at our last grand rounds a little later this month. Thanks.